So we'll go ahead with upper GI bleed. So how do you define upper GI bleed? So any bleeding occurring from the gastrointestinal tract proximal to the ligament of Treats. So that is known as upper GI bleed. And what will be the common presenting feature will be hematemesis with or without melena. So why does melena happen? Because the blood gets in contact with the hydrochloric acid in the intestine gastric contents, it is converted into hemetin. So this is excreted as the hematin in the stool presents as a blackish colored stool, which is melena. So for melena to occur, there should be at least 60 ml of blood. Okay, the etiology or the common causes of upper gastrointestinal bleed are most common is non-variceal bleed, that is the peptic ulcer related bleed, followed by other causes. The next cause will be variceal, that is esophageal varices. So the other causes of non-variceal bleed include esophagitis, tumor, angioma, malariviostia, erosions, Dialfo's lesions, okay, and polypectomy. The varices can happen not only in the esophagus, but it can occur in the gastric as well as ectopic varices. There can be rectal varices, there can be varices anywhere else in the body. Okay, but common causes of variceal bleed is esophageal varices. So the risk factors, when we look specifically into the risk factors for peptic ulceration, there should be a history of any antiplatelet use, any NSAIDs, NOVAX, or smoking history, H. pylori infections. For variceal bleed, history of liver disease or alcohol use, GI angioplasias, kidney disease or aortic stenosis, aortoenteric fistula, aortic aneurysm, or aortic graft placement in the past. Hemophilia, a patient with hemophilia usually has a history of ERCP or TIPS placement. Okay, and malariviostia, your patient will have history of kind of vomiting, retching, blunt abdominal trauma, so all these things. Malignancy related, any history of smoking, alcohol use, so all these are risk factors. So primarily when you're assessing a patient, so if the patient can be in tachycardia, there can be orthostatic hypotension, or the patient can be obviously, frankly, hypotensive. So when the patient is obviously hypotensive, requiring, if the mean arterial blood pressure is low, requiring some additional fluid resuscitation or vasopressor support, it means the patient is in category 4. That is a blood loss of more than 40% of the total blood volume. So this is severe hypovolemia. Whereas if the patient has orthostatic hypotension, that is decrease in the blood pressure more than 20 systolic or more than 10 diastolic, it means the patient has a blood loss of around 15 to 40%. That is moderate hypovolemia. Is mildly hypovolemic, the patient can have resting tachycardia. Okay. So the other signs what you can elicit is signs of peritonitis. Okay, the patient can have abdominal pain, guarding, and rigidity. The patient can have signs of aspiration, decreased oxygenation, okay, pulling of secretions, and then will be actively aspirating on the blood. Because of severe hypovolemia, the patient can become encephalopathic because of hypotension, and because of pre-existing liver disease, also encephalopathy can be there. And if the patient presents without any kind of obvious history of melena, a rectal examination in a hypovolemic patient will be helpful. Always your GI, when a patient presents with a GI bleed, a rectal examination completes your thorough physical examination. Investigations include complete blood count, doing a serum electrolytes, urea creatinine, LFTs, coagulation parameters, serum lactate, ECG, okay, X-ray to look for aspiration signs. Then you need to monitor the hemoglobin every 2 to 12 hourly based on the status of the patient and based on the amount of bleeding that is happening, severity of the bleed. So next will be how will you risk stratify the patients. So these are the various scores that are available. So the Blatchford score is the most commonly used score, the modified Blatchford score. So this has found to outperform the Rockall score. So the various parameters that are looked into the Blatchford score are the hemoglobin, which is different for men and women, the systolic blood pressure less than 110, which is considered significant, and there are various grades, the blood urea nitrogen, pulse rate more than 100, presentation with melena, presentation with syncope, hepatic disease, or cardiac failure. A total score of 0 to 21, wherein 0 to 1 is considered as a low risk score, and a score more than 6 needs intervention. So the Blatchford score is performed at admission. Okay, there is a Rockall score which is done at admission and post endoscopy. Okay, at admission, if the score is 0 or less than 4, the patient may not require admission. If it's 0, the patient may not require admission. If the patient score is less than 4, maybe an elective admission in the wards. More than 4, high risk patient ideally needs ICU admission. So what are the various risk factors it is looking into? Age, shock, comorbidities, okay? Based on cardiac failure, renal failure, shock in terms of hypotension, tachycardia. So, and depending on, so this is the pre-endoscopic scoring. And post-endoscopy, the score is complete. So based on the endoscopic stigmata, that is no lesion, no Mallory-Weiss tear, if there is peptic ulcer disease and it is just an erosion or esophagitis, it is low grade. If cancer, grade 2, and other signs of recent bleed like active bleeding, visible clot, so these are considered to be high grade. So the maximum score prior to diagnosis, that is prior to endoscopy, is 7, and the maximum score after endoscopy is 11. A score more than 8 gives a poor prognosis. The other score is the AIM-65 score. So in the AIM-65 score, they look into the albumin levels less than 3, INR more than 1.5, altered mental status, systolic BP less than 90, age more than 65. But maximum score is 5. A score more than 25 has a high risk of mortality. So these scores is not only for prognostication, it is for risk of rebleed as well as for mortality. So how will you manage a patient presenting with a GI bleed, upper GI bleed? So immediately, if the bleed is severe, intimate the medical gastroenterologist, intimate surgeon, and alert the interventional radiologist as well. Take care of your airway, breathing, and circulation. If the patient has a risk of aspiration or altered mental status, immediately intubate, consider endotracheal intubation and mechanical ventilation, and secure large IV cannulas. Okay, in central venous catheters and vasopressors if indicated, and volume resuscitation with large volume crystalloids to ensure the patient is not hypovolemic, maintain a mean arterial pressure of more than 65. Simultaneously consider starting a vasopressor infusion, and do not keep the map very high also. The patients can exsanguinate and bleed torrentially. So the hemoglobin target should be around 7. Okay. And maintain above 7. If there is an urgent need for transfusion, O negative blood can be considered. The severe ongoing bleed, you alert the bank and initiate a massive transfusion protocol as such. If the patient has been already on some anticoagulants or antiplatelets, consider stopping them immediately. Correct the prolonged INR or APTT. So if the INR is prolonged due to warfarin intake, then you will have to give FFPs at a volume of 15 to 20 ml per kg, or prothrombin concentrates. There are two types of PCCs, 3-factor or 4-factor PCCs. So you can transfuse either of them at a specific units based on the INR. So there are specific units that are recommended. For example, if it's 4 to 6, it will be at a certain value, units per kg. So you can give the prothrombin concentrate, then consider reversal of the anticoagulant activity with antidotes like dabigatran with idarucimab 5 grams IV bolus, rivaroxaban or apixaban with andexanet alpha 800 milligram IV bolus followed by 30 milligram per minute over 30 minutes. And this should be followed by an infusion, 8 milligram per infusion for 120 minutes. And if the APTT is prolonged or if there has been a heparin infusion which was ongoing, consider protamine sulfate to neutralize 1 milligram for 100 units of heparin that has been given. So for massive transfusion, you give 1:1:1, that is PRBC, FFP, and a platelet at that certain ratio. Okay, what are their targets? Your hemoglobin target is 7. Okay, and as per the NICE guidelines, correction of coagulopathy, your targets are platelet target 50,000, INR more than less than 1.4, APTT less than 1.5 times, maintain the fibrinogen more than 150. So these are the targets to be maintained. Next, so we have optimized the patient, risk stratified, initial management, reversal of anticoagulation. Next will be your specific therapies. Prior to that, there will be some pharmacological therapy that we need to institute. First, pre-endoscopic management of the patient. Is there any indication or evidence for tranexamic acid in GI bleed? No, this is as per the halted trial. So what did they find? There is no difference in the rebleed, but the risk of venous thromboembolism is very high when the patients were treated with tranexamic acid. So tranexamic acid is not recommended in GI bleed. Use of somatostatin analogs. So what are the somatostatin analogs? Terlipressin, octreotide, somatostatin. Dose being 2 milligram Q4th hourly during the first 48 hours followed by 1 milligram over 4th hourly. So octreotide 50 microgram IV bolus followed by 50 microgram per hour. Somatostatin 250 microgram IV bolus followed by 250 microgram per hour infusion. So these need to be continued 5 days to avoid early rebleeding. But if endoscopy has been done and if there is any lesion and the therapy has been done, endoscopic therapy has been done, then it can be discontinued after the next 48 to 72 hours. So is there any role for erythromycin? Yes, a single dose of erythromycin, 250 milligram, 30 to 120 minutes prior to endoscopy, it improves the endoscopic visualization because it improves the motility and clearance, thereby it improves visualization and it decreases the need for relook endoscopy. So nasogastric and orogastric tube can be placed and then continuous Riles tube aspiration can be maintained. Is there any role for antibiotic? Definitely yes, because there is a breach in the barrier between the blood and the gut, and there can be translocation, so bacterial translocation. So antibiotics, definitely yes. Ceftriaxone 1 gram IV OD for 7 days. Norfloxacin has been traditionally recommended, but right now we don't use norfloxacin due to risk of, because our organisms are always MDR bugs or the resistance rates are very high. So bacterial infections are associated with rebleeding due to increased heparin effect, increased endothelium. Actually, bacterial infections increase the bleeding. And due to various mechanisms, due to platelet dysfunction, due to endothelial 1 activation, which can worsen the portal hypertension, and there is some sort of a heparin effect also. So this is why you need to provide antibiotics, just not because of systemic infections, but also because of these causes also. And ensure the anti-encephalopathy measures are also given to the patient. And what is the indication for proton pump inhibitors. So if it's a variceal bleed, there is no role for proton pump inhibitors. If it is a non-variceal ulcer-related bleed, yes, there is a role for proton pump inhibitors. So what is the dose? 80 milligram IV bolus followed by 8 milligram per hour infusion continued for 72 hours. So how does it work? It increases the gastric pH to more than 6, so it stabilizes the clot. So post endoscopy, the proton pump inhibitors should be continued for 3 days, either as intermittent boluses or continuous infusion. In patients with high risk, patients who are high risk, that is Glasgow Blatchford score more than 2, it should be continued for 2 weeks. Ideally, during endoscopy, the rapid urease test is normally performed. If it is positive, then consider H. pylori treatment as well. So what is the regimen for H. pylori? When we look at the French regimen, clarithromycin 500 BD, amoxicillin 1 gram BD, pantoprazole 1 gram BD, 40 milligram BD has been administered. Some regimens consider quadruple therapy wherein metronidazole has also been added to it. If there is penicillin allergy, bismuth quadruple therapy, metronidazole, tetracycline, pantoprazole, and bismuth subsalicylate has been advised. So next, after you initiate the pharmacological treatment, important thing would be to go ahead with the endoscopy. So how early should endoscopy be done? Early as less than 24 hours. Urgent endoscopy less than 12 hours. Delayed is more than 24 hours. So what will be the endoscopic therapy for variceal and non-variceal bleeds? For variceal bleeds, if there are esophageal varices, variceal ligation should be done. For fundal varices, mostly glue injection will be done. First, if the patient has esophageal as well as fundal varices, the fundal varices should be approached first. Because if the esophageal varices are ligated first, there is increased risk of bleeding from the fundal varices. Then sclerotherapy is not routinely done because there is an increased risk of gastric wall necrosis and pulmonary embolism. Non-variceal bleed, endoscopic therapy involves adrenaline injection, more than 1 milligram diluted in 10 ml of normal saline, which is injected in grade 1 and 1A and 1B. Okay, it is only temporary, so there is a risk of rebleed. It should always be combined with some other therapy. So fibrin glue application. This is mainly for duodenal bulb where the clip does not stay. So ideal would be to do a hemoclip and adrenaline injection. Hemo spray powder, this is also something which is temporary because risk of rebleeding is very high and it is mainly for tumor bleeding. Hemoclip application compresses the vessel and the surrounding tissue. So the different grades, this is the Forest classification of the ulcer bleed, wherein 1 is active bleeding, 1A is spurting, 1B is active oozing. Okay, this has a high risk of rebleeding from 60 to 100%. Next is signs of recent hemorrhage, that is 2A, B, and C. 2A is a non-bleeding visible vessel, 2B is adherent clot, 2C is flat spot with a ulcer base, flat spot in a ulcer base. Grade 3 is clean base ulcer. So these are the various endoscopic therapies and the stigmatas. So in case of variceal bleed, what other therapies can be given? If there is refractory bleeding that is ongoing, not responsive to endoscopic therapy, or if the endoscopy therapy is delayed and not routinely available. So what can be done as a temporary measure? That is Sengstaken black and more tube or other tubes which can be done. So there are 3 lumens, the gastric suction port, the gastric and the esophageal inflation port. So there are 2 balloons, the esophageal balloon and the gastric balloon, which can be inflated and maintained at a specific pressure. So, and this compresses the varices and prevents bleeding. But this should not be done beyond a certain period, like beyond 24 hours. It increases the risk of ischemia, gut ischemia. So, some other alternative measure should be taken. Either a radiological intervention or a surgery should be considered. Other tubes that are available are the Minnesota tube, which has 4 lumens, one esophageal suction port, gastric suction port, and 2 inflation ports. Okay, this has an additional tube which can actually remove secretions above the gastric balloon. So this is Minnesota, and the other one is the Lincoln Nachlas tube. So the next therapy which can be considered is radiological interventions, that is for non-variceal. So if there is a recurrent bleed despite the endoscopic therapy, consider transarterial embolization. Surgery in case of failed embolizations, and then if the lesion is something that is neoplastic and some vascular abnormalities like diaphyseal lesions, aortoenteric fistulas. So these are the lesions which should be treated surgically. So ultimate treatment for variceal bleed, refractory variceal bleed would be transhepatic transjugular intrahepatic portosystemic shunt, that is TIPS, wherein there is they decompress the portal pressure by creating a artificial bypass between the portal vein and the hepatic vein. So this the indication for this TIPS would be recurrent and uncontrolled variceal bleed. So contraindication, the main complication of TIPS would be hepatic encephalopathy. So contraindications in a patient who is already encephalopathic, this will definitely worsen. So hepatic encephalopathy is a contraindication. Also, it increases the pulmonary pressures. So portopulmonary hypertension is a contraindication. Portal venous thrombosis, if there is a already pre-existing clot in the portal vein, that is a contraindication. Hepatic failure with reduced ejection fraction, and child classification C. So these are the contraindications for TIPS. Okay, so you have done the control of the bleed. So some patients who had already been on antiplatelets for coronary artery disease, they have to be restarted on their medications or antiplatelets. So when will you consider restarting these antiplatelets in non-variceal, that is ulcer-related bleed? So you look at the risk, okay, if the cardiac risk as well as the risk of rebleed. If the patient's endoscopic stigmata is Forest 3, that is low risk of bleeding, and hemostasis is achieved in the next 24 hours, you can restart aspirin. Okay, if the cardiac risk is low, then you can wait for 48 to 72 hours. If the bleeding risk is very high, that is a spurting or a oozing vessel, the decision to start the thrombotic therapy should be considered actually. It should be discussed with the cardiologist and then decided.